Welcome everyone, and thanks so much for joining the session. It looks like we've got most people here, so we will make a start, but I'm sure some more people will keep trickling in. Great to see you all. I can see a few kind of familiar names in the audience, but for those of you who I haven't met, I'm Matthew Hill. I'm the Head of Insight, Evaluation and Research in the Q team. So I hope you've all been really enjoying the Q community event so far and found the morning sessions really energizing and thought-provoking. I know that I did. Next slide, please. So just to go through a bit of the tech first, so subtitles are available. If you click on the live transcript button, you'll be able to access those if you need them. If you'd like to be in a breakout with transcripts, just let Beth Banfield know and she'll be able to arrange that. Do keep your videos on. It's great to kind of see people through the discussion. You can join the conversation on Twitter at the hashtag #QCommunityEvent 2022. And if you do have any issues throughout the session, just message Beth Banfield and she'll be able to hopefully help you out with those. Great, so we're here today to have hopefully a really kind of honest and productive conversation about reducing weights and improving equity, and crucially, what it takes to do this well. The session title says, you know, we can't achieve one without the other. I guess that's not strictly kind of factually true, is it? You know, of course, we can reduce weights without improving equity. And indeed, that may be a more kind of straightforward, simpler path. I think what the title's trying to get at is more of a kind of call to arms, a call to action to ensure that as we kind of tackle weights in this current context, that it has to include that kind of focus on equity. Knowing what we all know about the kind of scale and consequences of inequitable access and wider health inequality, you know, especially as they've kind of come into sharper focus during the pandemic, we've just got to ensure, haven't we, that the recovery is as inclusive as possible. That said, what we know, including from what we've heard from Q members, is that this work is not easy. You know, it can be really difficult and demanding for those doing it. It often requires them to challenge their colleagues, their organisations, themselves, to really think and work in a different way. So there is that urgent need on the one hand, but also recognising the kind of scale of the task and the many other kind of top priorities that are out there at the moment. So we've designed the session to that end. So we really hope it's going to create the opportunity to hear from the case studies who've had, you know, real success in this area. And it'll hopefully help us all to kind of think about our work in a different way and unlock new thinking. We'll be running the session using the liberating structure celebrity interviews. Some of you might know this method. We're using it because the format really gives people the chance to kind of actively contribute to the session. And hopefully it gives us all a chance to explore the relevant learning that most kind of resonates for us in our work. In a nutshell, we'll start by asking questions of our speakers to hear more about their work and what they've learned along the way. We'll then have time for some individual reflection and small group discussions in pairs and fours. So we'll use the 1, 2, 4, all method for that. And in these small groups, we'd like you to generate additional questions for the celebrities, for the case studies. And we'll all be coming back together at the end, where we'll have time for each group to ask their kind of top question to the panel. I should warn you, this 1, 2, 4 method can feel quite abrupt. Please don't worry about this. It's part of the method to kind of engage everyone in generating questions quickly. Okay, so just to do a quick check-in to get everyone warmed up, I'm going to ask a few questions. Some are easy, some a little more, hopefully a little more thought-provoking. It's meant to be fast-paced. Just share your initial responses, what comes to mind first. And just pop your answers in the chat to hopefully get everyone warmed up. So the first one is a nice, easy one. On a scale of 1 to 9, how are you feeling about this week? Which of those felines best represents that? Quite a few 3s coming through. I think that's pretty calm if I'm reading the face right. Glad to see no 9s coming through yet, although hopefully we'll get a bit of that more feisty energy through the session. Good stuff. Keep those coming through. Second question, hopefully a little bit trickier. So just finish this sentence for me if you can. So when I hear improving equity, I think about, when I hear improving equity, I think about, yeah, there's a challenge, being fair. Yeah, some of the social determinants of health. Great, a few different reflections coming through there. Great aspirations around that. And the final question, third and final question to get everyone warmed up, is the most challenging thing about improving equity is. So again, just finish that sentence for me. The most challenging thing about improving equity is. Yeah, a few challenges coming through, a lot of balances, yeah, a lot of trade-offs there. Great, I'll just give it a few more seconds for those to come through. Fantastic. Okay, hopefully that's just warmed everyone's brains, if not at least your fingers, but at the start of the session. Before I hand over to the panel, I just wanted to share some emergent learning from a current Q Insight project that we've got in this topic, that I'm hoping will just provide some useful input to the later discussion. So we've been using an action learning approach with 2 cohorts of Q members who are undertaking work around data, access and inequalities. We've been working with them for around 6 months, and it's been a great opportunity to kind of explore some of the live challenges and issues that people are facing with a group of peers in that kind of safe space. But we've also tried to draw out kind of emergent insights as we've gone along the way for wider kind of use and relevance. We will be publishing fuller findings in the new year, but we've already shared some of the emergent findings as we've gone, including the kind of sketch notes and these 6 key themes on the slide. So really briefly then, we've drawn out these 6 themes, which, like I say, I hope are relevant for the discussion today. Firstly, we've really heard how the current focus on inequalities can be a golden thread through improvement work. So we've had this sense of really kind of palpable momentum and urgency around this topic within organisations and to some extent at the system level. But we've also heard, like I say, that there are many challenges, you know, firstly around the kind of quality of data, missing data, fragmented data, data maybe not providing the nuances of people's lived experience, and some of the challenges around kind of navigating those data issues. And I guess relatedly, some of those challenges around turning data into action. I guess these are more kind of cultural, I guess, issues, challenges around how data is integrated into decisions, how to coordinate action across the local system level, and how to use data to challenge those behaviours and ways of working and thinking. So after we drew out some of those 3 challenges, in our second set of insights, we tried to point towards some areas of focus that the group were drawing out. Firstly, the need to kind of be strategic around how we approach this work in the context of winter pressures. It's tough out there, isn't it? And it's going to get tougher. So the group felt we really need to identify opportunities now for how we're going to progress this over the next 6 months or so. As well as being really upfront about where the gaps are in our expertise and perspective, and finding allies and partners to kind of help plug some of those gaps to make progress. And finally, I guess not so surprisingly from a group of Q members, they really emphasised the need for a collaborative and systematic improvement approach to some of these challenges, having a clear purpose, learning as we go, challenging assumptions, including our own, and crucially kind of co-designing solutions with patients and others who are directly affected. Okay, so I just wanted to share a few of those initial inputs and kind of flag that project. Like I say, we'll be publishing more in the new year, but I hope that was a useful input. Without further ado, though, I'm just going to introduce the panel and we'll get cracking with the celebrity interview. So, firstly, we've got Clifford Mitchell. He's the Regional Senior Improvement Advisor for the Improvement Hub at HSCQI, and he's our interviewer for today. So great to have you in that role, Clifford. And then our celebrities, our case studies are Amy Bowen, Director of System Improvement, North London Partners in Healthcare, and Professor Kiran Patel, Chief Medical Officer and Deputy Chief Executive, University Hospitals, Coventry and Warwickshire, NHS Trust. Clifford, I'll hand over to you.
That's great, thank you, Matt. So Kiran, Amy, fantastic to have you here today. You may have maybe noticed from my accent, I'm from Northern Ireland. You may have noticed it's a wee bit like that. And in Northern Ireland, it's an exciting time for us. So our HSEQI network is just starting a regional programme focusing on safe, timely access, and that's across health and social care. So I'm really interested in hearing your perspectives, and I'm sure there's many in our audience as well that are involved in similar work and maybe at different stages. So it's great to hear your perspectives. So I'm maybe just going to start with listening to a bit of the work that you're doing. So maybe start with you, Amy. Would you tell us a little bit about the work that you've been leading on?
Sure. And, you know, I can slightly match your Northern Irish accent with an American one. North Central London has the dubious distinction of having one of the longest waiting lists, elective waiting lists in the country. So that attracted, you know, some additional funding. And so we were an accelerator site, and the CCG, as it was at the time, made those monies available for people to bid against for new initiatives. So we put forward a bid to use our new integrated data set and population health management platform to build a dashboard of the elective waiting list that we could make visible to the whole system. So primary care was able to see the waiting list, and we were able to put a whole bunch of clinical and demographic filters onto that so that we could look at that list through different lenses of different geographies and also different demographies in our population, and think about putting in place some proactive interventions in primary care to either optimize people who are waiting for an intervention to have better outcomes, to remove people from the list with their participation and consent because there was a better alternative available in the community, or to change their priority on the list because of things that were going on. So it was a chance for us to start to demonstrate what a population health management approach and a proactive approach might look like when applied to a system problem like elective recovery. So we created these proactive integrated teams, or PIT teams. And I keep having to say to people, it's PIT like a pit crew on a racing track rather than an abyss. But the teams were multidisciplinary teams set up to work across the interface between primary and secondary care, to have an impact on people's experience, access, and outcomes in elective recovery. So that's probably the outline for you.
That's brilliant. Thanks, Amy. And over to you, Kiran. Can you give us a bit on the work that you've been doing?
Yeah, hi, thanks, Clifford. Pleasure to be here. I guess, you know, very similar to Amy, we use data, and during the pandemic, we found that the social gradients that we know exist in terms of access to emergency and urgent care and elective care were starting to be exacerbated. So the evidence tells us that actually more deprived populations tend to use front door urgent services disproportionately compared to more affluent populations who tend to use elective care. So there is a pre-existing gradient. And that work was done by the commissioning support units back in 2016. But of course, that started to get steeper throughout the pandemic. And we saw this and started to think, we don't want to come out of the pandemic looking like this. So we started to do some work on designing a scheduling tool for elective care to try and address some of those inequalities. And the first thing I would say is we absolutely want everybody to achieve their NHS constitutional standards. But of course, within that, there are inequalities that we see in terms of access. And we had data, if I was to give you an example, saying that there was a 7-week access inequity in orthopedics for elective care for us. And it's data like that which sprung us into action to say, could we do better in terms of clinical prioritization and use clinical prioritization as a tool, not just to look at RTT and waiting times, but actually look at clinical outcomes. So the population level, what gives you the best clinical outcomes for your population? And, and if you had a cancellation coming up tomorrow, rather than call your patients at random, how do you know the next patient who's likely to benefit most from that slot? So we developed a tool which is quite sophisticated in embracing evidence-based clinical factors that drive outcome and coupling them to operational factors that drive outcomes. So issues such as waiting times. And you can provide different levels of waiting within that tool. So for example, we heavily weighted patients waiting over 104 weeks, regardless of any other factor. So we quickly managed to remove 104-week waiting patients as a cohort. And as we then built sophistication on the back of that, we found two phenomena emerged. One is that waiting times for everybody got better, but actually we started to level up as well in terms of waiting times. And, clinical prioritization falls within 3 programs of population health work. One is proactive case finding, so you can use data to identify where you're not seeing patients from. The second is prioritization per se, which is what I'll focus on today. And the third is coupling it to what I call active waiting and imparting prevention opportunities at scale to everybody on a waiting list. And through that, our clinical tool has started to improve outcomes. We've started to see improved access for all of our populations, but narrowing the gap within it as well. And going forwards, we have the ability to embrace issues such as clinical status reviews, so that if the status of a patient changes whilst they're on a waiting list, their position on that waiting list can change. So it can become agile to clinically meet patient needs, rather than just accept that everybody is on the same conveyor belt. And then, of course, we've also embraced a debate about social value judgments. So should we impart those into patients who are on a waiting list? And of course, we know that the majority of health outcomes are determined by social factors. So actually, how do you use those to get best outcomes at a population level? So we commissioned a piece of work with Ipsos Mori, which some may have read, and we've opened up the debate about saying, are we serious about tackling health inequalities, and how far do we go in terms of our ambition?
That's great, Kiran, thank you. And I suppose over the next sort of 20 minutes or so, we'll maybe explore some of those things. So I've a number of questions, but I'm actually just going to pose them to both of you. So feel free to chip in or interact. But the first one's more of a reflective type question. So if you think about the work that you've done on the focus on improving weights and improving equity, can you each describe a peak experience or high point, maybe something that inspired you or impacted on you personally, or a bulb moment where you thought, yes, we've cracked this? Maybe go to you, Kiran, first. Amy's looking up.
I'll probably kick off what Amy's thinking. So I recall during the height of the pandemic, when we were pushing our clinicians to do as much virtually and remotely as possible. And I received a letter from a patient saying that she thought this was a fantastic thing to do, but did I realize that she had to go out and spend £14 of her £28.50 a week of benefit on purchasing a mobile phone and some credits. And unfortunately, by the time she'd been connected, she only had about 20 seconds left for her appointment. So she couldn't afford to attend her next remote appointment. And was there any way that we could schedule a face-to-face appointment for her? And that was the light bulb moment for me, saying, actually, sometimes we make an assumption of what's best for our patients without appreciating their socioeconomic status and the things that drive their health-seeking behavior. So for me, that was the light bulb moment that said, actually, I had to do something here. And to get the same outcome for every patient doesn't mean necessarily providing the same input and process. But that's what we always do in the NHS. So if we are going, I passionately believe, if we are to drive a clinical outcomes focus driven population health management program, we've got to appreciate that we have to do things differently and differentially.
I really, that really chimes with me. This point about, I was the one who put the comment in the chat about the kind of differential effort to achieve outcomes. I just think that's so important. And it's something we've been learning in all sorts of ways over and over in our population health work. But the reason I was looking up is that there's actually two things that I couldn't choose. I hate these when I have to come up with one. So I'm gonna break the rules a little bit and pick two. But I promise to be brief. The first is when the pit in Haringey, one of the Haringey PCNs, who were really, all of primary care found it very revelatory, I think, to see their own waiting list. It's not something they've ever had access to before. And when they were able to identify an individual on a waiting list with a serious mental illness and be able to proactively put in place the support that would enable that person to attend their appointment that otherwise they would have DNA'd, they felt they could feel the power of possibility in front of them, because there was a very straightforward intervention in their current toolkit that they could deploy because they had access to the information about who was coming up to the front of the queue, and they could reach out proactively and support proactively to help that person have an equitable opportunity to have access. So that's one thing. And the second thing is one of our other pits has done such amazing work across the boundary between primary and secondary care. And nobody will be surprised that the key thing they've done is form relationships. People have come to know one another and figure out that they've actually got a common purpose and a kind of shared challenge. And if they work together, that they're able to make best use of everybody's resources. And so they've created new processes and pathways that allow them to identify the right people to speak about and speak about together. And they're beginning to get a kind of, pick up the phone relationship with one another and build that specialty by specialty. And that feels like these sorts of things feel like the future. I mean, you start to see them begin to happen. It's really energizing.
Yeah, and I suppose that's a good word. It's the energy that drives things forward. And I suppose when we talk about energy, I suppose my next question's going on, and it's maybe a bit of a struggle. How do we ensure the balance of focusing on performance and the performance data versus the so what? So, the clinical outcomes, the impact, patient experience, equity, and then how do we effectively capture this and, more importantly, act on it?
So there's a tension, right, between efficiency and equity. They're often more challenging to reconcile with one another because of that differential effort point, right? So the most efficient solution in the short term isn't always the most equitable one. And so we have to live with that tension. And it comes back, I think, to Kiran's point about the data, that we need to underpin this with really, really good evidence for when we are going to, shift the relative importance or make the trade-offs between one and the other. We can't make them go away. They'll always be a part of trying to do population health improvement well. But if we are honest about that and we have good data to drive that decision making, because sometimes there will be times, I think, when there will be a very credible reasons why efficiency has to, in a particular circumstance, be in the foreground.
Yeah.
But we have to understand what the consequences of that for equity are, and vice versa, and be honest about that, and as a mature system, be able to accept those trade-offs.
Yeah. Do you want to add in anything, Kiran?
Yeah, Clifford, I think this brings to the fore the relevance of urgent and important, doesn't it? And if you take the litmus test of which elective recovery and health inequalities are, we've got the urgent and important, and our challenge is how you combine the two. So I'd say it is urgent to try and get elective recovery underway and meet those performance metrics and hit the constitutional standards. But it's also important to try and reduce inequality at the same time, because if we don't aspire to that ambition, what happens is we restore services based upon waiting times alone. And there is ample clinical evidence out there in terms of publication that tells us a focus on waiting times alone drives inequality. And none of us would want to see elective recovery coupled to widening inequality. But I fear that's where we are at the moment, unless we take on this ambition.
Yeah.
Clifford, can I just put a little tidbit from North Central London into the discussion? Because when we did our analysis, we found out that demographic factors were not the big driver of differences in access. The biggest driver was whether you were a patient of a particular hospital, acute provider in our patch who has, I know we're all talking about eye-watering things at the moment, but huge waiting lists. And actually, whether or not you were a patient of that particular provider had much more of an effect on your waiting times than your demography.
Yeah.
So then that raised all kinds of questions about and generated lots of work around mutual aid and a kind of different way at looking at our system waiting list. So it comes back to the evidence behind. We just need to test some of our assumptions all the time with the data in front of us and make sure we understand what our drivers are. Not to say there aren't demographic factors at work as well, but there is one really great big one, which is about which provider you happen to be a patient of.
Yeah. And do you think, I know speaking to some colleagues, there's a perception around the culture around sharing data and openness to share data. Have you come up with any sort of issues around that?
Oh, no.
No, that's good.
Well, I can say a little bit, and I'm sure Kiran has also got his perspective on this. But I mean, we have an integrated health and care record in North Central London, so we've come quite a long way down that road, and we have a population health management platform which is being implemented across the system. But the pits helpfully have surfaced all kinds of practical issues about how you make that work on the ground, particularly around things like case finding, and some of the kind of ethical as well as governance questions that sit behind what it means to work as a system and what mutual accountability for outcomes actually means. So it has given us a kind of practical basis for all kinds of questions that we're still trying to figure out how to answer. To be honest, we haven't got all the answers to all of those questions, but they're really important ones to enable us to work properly as a system.
Yeah, I think the concept of sharing data is relatively straightforward in that none of us would deny that we wouldn't want to share data when it's in patients' and population's best interest. The reality is actually informed patient behavior. And of course, we saw a national program that aspired to tell patients where waiting times were shortest in their country and asked whether we should enable patients to travel there. Quite often patients want local services, don't they? So we're going to have to wrestle with quite a hybrid approach of saying we'll probably end up serving two populations, those patients who want to remain local and another population that is defined for us. And again, if you take an integrated care system and you take a macro level population, ultimately, if we want to shift resource to address inequality, we'll have to move money essentially between different parts of those populations if we're starting to tackle this seriously. And that takes us into very upstream interventions when it comes to addressing the social determinants of healthcare and moving between local authorities. So this is a highly political, contentious issue, of course, and the health service can play its part, but it's not simple. Yeah.
And there's a whole green agenda that sits alongside that. If you offer people the opportunity to travel more, that it has an impact, doesn't it? It has an environmental impact as well. And how do we reconcile those different agendas sensibly? Short and longer term urgency is also hard to square off.
Okay, thank you. I suppose, and this is, I have a bit of a personal reason for asking this question, but hopefully there are others on the call here who can sort of link in with this. And it's around, we do work in complex systems. And and teams are addressing this sort of all at the same time, but we're all at different stages. So what advice would you give to those systems or teams that are just starting off in addressing these issues around long waits and equity?
So I'll kick off this time here while you look up and choose between the two. Rather than choose between two, I'd say two things. I think, first of all, reassure the public that they will achieve their constitutional standards, because we wouldn't want to deny that to anybody. So then there is universalism in what we're trying to achieve. The second thing is to engage the public in what you're trying to do. And I say that because we commissioned independently Ipsos Mori to do a great piece of work to engage the public in what they felt. And some of you may have read some of the sort of rather sensationalist headlines about that. But what it showed us is that there is naturally a breadth of public opinion in the appetite to reduce inequality. So just because we think that it might be morally and ethically the right thing to do, it doesn't mean necessarily that all of the public agrees with us. So we have to get better at articulating what we are trying to do to the public and the citizens that we serve. Because I think, if we address health inequalities, then we get it right for the entire population, not just for a segment of it. I'll hand over to you.
I keep looking out the window because there's a tree outside my window, and that's what is drawing my eye to. So,
Trees are inspiring.
So I guess I was going to come at it from a slightly different angle. I think our experience around the pits has taught us a few things that I guess it's reinforced things I've learned other places. One is to assume good intent. People want to do well and right for the people they serve. And so we had so much positive response to the opportunity to help blaze a trail in terms of a new way of working. And we had a kind of outline model of how we thought this could work. But I think bringing the teams that came forward to participate, and we targeted PCNs with long waiting lists, high levels of deprivation, and a high prevalence of long-term conditions. But kind of working with them, letting them all approach a common problem in their own distinctive way, generated much more learning than being overly prescriptive about the model. We were clear about the vision and we were clear about the outcomes, but we really wanted to encourage them to chart their own course to getting there, and then created a bit of a community of practice amongst what started out with 5 and became 10 teams, so that they could learn from one another and be there to hear what the barriers were and do our job as the ICB, which is to help create the conditions for them to succeed. And for me, that's been the biggest bit of learning, is to get the vision right and get the outcomes right, and then give people room to create, because people have really great intent and fantastic instincts for improvement if we give them the space to do it.
Brilliant, thanks. Well, Matt's maybe going to shout at me. I think we've maybe a minute left. So I want to wrap up on just this last question, and maybe that it'll bring together some of the things that we've just talked about. And this is so looking to the future. So hypothetically, so if we can imagine our NHS 5 years from now, and where all patients are treated fairly with equity, right care at the right time, what would be different? What would have changed, and how would we have enabled this? Easy question.
Whoa.
I'll be very quick. I think we'll have achieved personalized healthcare by defining the exact outcomes every patient wants in discussion with the GPs or clinicians. And I think by defining the expected and wanted outcome, we'll be able to deliver that.
That's a fantastic answer. I really go with that. And I think we would see care much closer to the served community, much more of the full pathway of care, much closer to the served community.
That's great. Well, thank you. It's been great speaking to you. I wish we could speak for longer. I'll pass you over now. We'll go back to Matt.
Fantastic. Yeah, thanks so much, Clifford, and thanks so much, Amy and Kiran. Good news is we will have a lot of time at the end of the session to come back to some of these threads and pick away at them in a bit more detail. So hopefully some of that discussion has kind of sparked lots of thoughts for everyone in the room. We're now going to kind of work individually and in small groups to generate some more questions for the celebrities for the case studies. So we'll just spend 2 minutes now just reflecting individually. So just make a note of the kind of questions you've got for the case studies. Then we'll move into pairs and then into fours before coming back. I'll say a little bit more before we do that, but just reflect individually. Great stuff. Okay, we've got people coming back to the main room, which is great. Hopefully, yeah, you generated some useful questions and discussions there. So what we'll do first is we've got the 4 groups, so we'll just take each group in turn in the order I've got written down, and then open it up for further questions. Clifford's got plenty more that he wants to put to the celebrities as well. So I'll just call each group. So it'd be nice to hear the questions verbalized if that's all right. If there's any issue with that, please do just add it in the chat. But so the first group would someone from Debbie, Libby and Sarah's group ask the question to the panel. And then we'll hear the answers first before coming to the next group.
Okay, so this is a kind of multi question and multiple elements. The first one is, so it's redirected to Kiran. We were really interested in what you talked about in terms of, it sounded like you had some kind of tool or model for finding your long waits, but then also moving the whole curve improved, the whole waiting list reduced. So we wanted to know if your tool was replicable elsewhere. We can't believe you haven't written a paper or someone hasn't published or something. Is there something out there that can be shared more about it? And then linked with that, we were interested to know how you had weighted the various clinical and operational variables within that. And the third part is, and what expertise is needed to do this kind of work. Libby, hopefully if I have captured what your bit as well.
Okay, 1 question with 3 clauses. We'll let you off on that. Okay, great. If Kiran and then Amy could come back on those.
Yeah, gosh, I'll try and be quick. So I could probably spend 3 days answering that one. But again, so what we've done is developed a tool which embraces all of the clinical factors and operational factors that drive outcomes. In terms of weighting, the answer is we don't know how much to apply in terms of weighting because the evidence on multimorbidity is relatively weak, and that's a whole area of research that is now starting to pick up. So we've equitably weighted each of those factors, but the most significant one where we had an impact was using waiting time alone. And when we used that as the significant factor and we applied it to the entire population data set, we saw a reduction for everybody, but also a narrowing of the gap. And what did that tell us? That tells us that there was a disproportionate number of patients from more deprived backgrounds waiting longer. So applying that same challenge for all patients had the same outcome, but a differential impact. It narrowed the gap. So I think that's probably step 1. But then going on from there, you then need to apply through the algorithm all of those clinical evidence-based factors that drive outcome. And we're still developing this. And the basic tool is available for people to use, but we will publish based upon this. We've got some qualitative papers awaiting publication, but we'll publish based upon the outcomes and the impact of the studies. But the reality is we just don't know how much to weight each of those factors. And we've got some interesting ones in there. So we're trying to move people away from urgent and emergency care into elective care. So if a patient turns up to A&E with their chest pain 5 times and they're waiting for their cardiology appointment, actually, do you use that as a factor to say, well, prioritize your elective care so you don't keep going to urgent and emergency care? And those are the kind of thought processes that are all, it's great that they're surfacing and they need to be discussed and addressed. But at the moment, we collate all of those factors, put them through an algorithm, and we will put some AI and machine learning into what we're doing as well. So I hope that answers all 3 parts in a nutshell.
Amy, I don't know if you wanted to come back on any of that, particularly the last part of that question.
Only to say that in Healthy Intent in our platform, we can see and stratify by waiting times, as well as adding in other factors such as diagnoses of long-term conditions, whether people are known to social services, people, inclusion, health sorts of issues, as well as other demographic factors. So we've been able to ask the PITs to focus on our cohorts that have been waiting the longest, to try and understand what kind of support is needed. I mean, one of the things that we haven't really talked about, which has come out in a lot of our work, is the number of people who are on the waiting list that needn't necessarily be there, because there are other alternatives in the community that are well matched to their need, or people who are on multiple waiting lists, either for different problems or for the same problem at different providers. So from a system perspective, there's been a whole exploration of that challenge, that, you know, we have people on the list that for a host of different reasons whose needs could be met more effectively and probably more quickly in another way. And, you know, a lot of people have tried bringing third parties in to do some of that work, and I think there's mixed evidence about the benefits of doing that. And, you know, we are certainly finding that fostering those interface relationships within the system itself is the best way to try and, both with the current backlog, try and make sure that people who are on the list are on the list only once and for the right reasons. But also it points to some of the kind of sustainable changes in the referral pathways that we could think about making to prevent just the concertina effect. You know, you bring the backlog down, but you keep your referral behaviors are the same, and so the list just keeps expanding. And so yeah, I think there are multiple different ways of looking at this challenge, and the system perspective does yield some different considerations.
Fantastic, thanks so much. Okay, moving on to the second group. So someone from Darren, Joe and Sam's group, if you could unmute yourselves and share your questions.
Do you want me to give it a go? How do we work with community assets to give us better access to communities in order to reduce waits and increase equity of access?
So I can say a little bit about this from the PIT perspective, and I have to say that the PITs are, I think, a kind of fuller model in microcosm. You know, they have a lot of the characteristics and attributes of at a smallish scale of what we might see in a kind of fuller informed neighborhood. And you know, hence my point earlier about bringing care much closer to the served communities, making sure that more of the people providing services are representative of that served community. The use of health coaches and health coaches that are drawn from the served communities has you know, a good solid evidence base behind it. So and I think we definitely as a system have a very long way to go in terms of some of our engagement and co-production skills and our consistent use of that. You know, I think it's still, if I'm honest, not something we do upfront with as much with as much purpose as we might be able to. So I think there is a lot to do in terms of making that kind of neighborhood context really flourish, and having a system that is committed to listening to the served communities and working to people's strengths, not just their deficits. I'm a nurse by background. A lot of us were trained in a kind of deficit model, and this is really about shifting to a strengths-based model.
Kiran, did you want to come in on that, or?
No, not particularly, other than to say I think Amy's absolutely right. Use the communities as the portal of access rather than impose a portal of access.
Great, thanks. Okay, moving on to the third group, which was Donna, Kevin, and Tanya. So someone could come in from that group.
Yeah, hello there. Thanks, Matthew.
Hi, Kevin.
I think we're getting close to answering our question, but maybe we're still not there yet. It says, how do we design in personalized care to address things like intersectionality rather than individual diversities, which not many people have really, for every pathway? So, you know, if you were going to give a checklist to tell people how to get this done, what would you put in place when designing a new pathway or a revised pathway that would ensure that personalized care was embedded throughout that pathway and thereby addressed diversity and intersectionality?
Nothing like a great big question. It's a really, really good one. And I guess it is the preoccupation of all of us working to try and bring a population health improvement approach to life. So that's not to dodge the question. That's, I guess, just to acknowledge that it is really challenging. I mean, we've got concurrent bits of work going on that are all trying to line up around an approach. So we're doing a great big piece of work around the primary care model for long-term conditions that is based around three things: the house of care, of year of care, and personalized care and support planning, and trying to embed that in a kind of stratified way for the known population of people with long-term conditions, to try and get a much more consistent approach to proactive care in long-term conditions going at that end of the pathway. And that becomes a really important input, right, to a pathway that is starting to transform. And I think there's a whole thing about the referral space and the personalization of how people get referred, why they get referred, where they get referred, how they're supported while they're waiting, that we still have a long way to go to get right. I think there's a lot about that chunk of the pathway that we're still tried lots of different methodologies to try and make that work, and I don't think we're quite landed on the best one. But I guess I believe very strongly in two things. One is this point about mutual accountability. Say, from a systems point of view, we need to move to a world in which everyone who's in contact with a patient feels accountable for the outcomes that they achieve, and that they aren't sectoral, they're systemic. And that's a whole OD and culture change piece of work to move us into a different way of seeing it. And the data is a big enabler of that. And I think also recognizing that our one of our greatest system assets is the one that we make least use of, which is the strengths of the individual. And I think we've got a lot to learn from our local authority colleagues about how to do that. And I think unless and until we get those two things going much more consistently, we won't get to that personalization that you so eloquently described.
Yeah, I guess, Amy, the only thing I would add to that is on the concept of personalization. I remember something Muir Gray said a while ago, which was, don't ask what the matter is, ask what matters.
Yeah.
And I think we're quite, we've got a long way to go in terms of capturing that. And that drives us towards using resources appropriately, because at the moment, I guess, I'm a medic myself, but I think we have quite a patronizing overview of the healthcare we deliver. So I think we assume we know the outcome that patients want, whereas actually sometimes it might be quite different, And if you take cancer care, for example, actually some patients may just want a good quality of life to spend a month with their family rather than a poor quality of life for 6 months when they can't see their family as much. So I think, how do you capture qualitative data is a real challenge, because I think we're good at capturing alphanumeric data sets, but it's the qualitative one that's often most important for patients.
It's such a good point, and we talk a lot in the ICB about, you know, intelligence functions and, you know, insights and all of that kind of stuff, all really, really important, but that's got to be both qualitative and quantitative. We cannot forget to develop our capabilities and our commitment to both. The other thing that Mira always talks about is not specialists, but partialists. And I've always really liked that concept, is that, you know, what we're trying to do is something holistic, not partialist. And a lot of times when you see somebody for a particular problem, you get that partial view. And we're trying to create a system that is always focused on the whole person.
Brilliant, thanks for that. And then onto the final group. So Jill, Karen and Olivia. Can someone from your group come off mute and ask a question?
Hello, we were going to ask about individual needs being met, but one of the challenges we wanted to ask about was, how do you get the finances to follow the patient, where the services are divided and provided in a different way?
Ooh, yeah, exactly. And you know, we talk a lot. I'm sure everybody who's working in a system somewhere is having exactly the same conversation about, you know, no one can afford to double run. We know we need to move more things upstream. We know we need more emphasis on proactive and preventative interventions. But, you know, our current system has a lot of resource tied up at the downstream end of the pathway, and, you know, we can't afford to double run. So what are we talking about? You know, are we talking about a leap of faith here, that the theory of change is real enough? And how do you persuade partners in a system who will bear the financial burden of that in the short term, even though the benefits will be reaped in the longer term? How do you bring them into that theory of change meaningfully? It's really, really, really challenging. And, you know, can we describe a kind of tipping point where you try and minimize the amount of double running you have to do? You know, what does that actually look like? But we've certainly been focused a lot on outcomes-based models, weighted models. How can we start to think about financial models that operate very differently than the activity-based ones? Because counting widgets certainly ain't the right answer. So we definitely need something different. So what are those new models start to look like? That wasn't a great answer, was it?
Yeah. I think you tried well. I mean, I guess I'd answer the question with a question. You know, do we commission for health outcomes, or do we still commission for activity? And I think if we are going to genuinely commission for health outcomes and based upon population health management, we need to take it more seriously, don't we? And that means having a differential envelope based upon the populations we serve. And at the moment, we have a formula that weights everybody equally across the country. And if you're serious about addressing health inequality, we need to weight that formula so that we don't just deviate to the mean, but actually we have a much more sophisticated funding envelope.
I agree, but there's the interdependent nature of delivering outcomes then that is also at play, right? So we know that it's not just a sectoral thing, it's how the whole pathway works and how we collaborate around the needs of the individual. So we talk a lot about how do we shift from a demand-led system to a needs-led system. You know, we are going to have to believe in our theory of change. Ultimately, if we're going to make it a reality, we're just going to have to kind of, you know, metaphorically, obviously, hold hands and go for it. I'm sure we're not going to actually hold hands, but, you know, I think that is what it's going to take, because the money is not there for us to run two systems concurrently.
Great, thanks so much, and thanks to everyone for those questions. Just before we wrap up, I'm just going to forward Clifford as the interviewer the privilege of just asking one more question to Amy and Kiran, and then we'll wrap it up after that. So Clifford, over to you.
Okay, well then I'll finish with an easy question. Not. So, you know, the past two years have just been, you know, mentally and physically exhausting for our staff at the front line. You know, there's staff burnout, mental fatigue. So how do we support our frontline staff to have the headspace and to become actively involved? So, you know, we're talking about this is the way we want to go. This is our change theory. How do we support them to become actively involved? And how do you successfully bring people along with you?
I'll try and make a start at that. I guess twofold. So certainly in our organization at UHCW, we have an improvement methodology which tries to define the challenge we're trying to address and then apply improvement methodology to anything we're trying to solve. So I think having an approach is really important. And then secondly, I would say create some headroom for your staff to take them away from the reactive, urgent work that we have to do every day, which creates that burnout you mentioned, Clifford. So, you know, I try to segment the work we do into urgent and important and reactive and proactive. And I think it's important to get into the proactive stage. And when I lift my clinicians out into even a couple of hours of saying, right, let's just brainstorm something completely novel and new, it energizes them because it takes them away from just having to address the same thing day in, day out. So I think we've got to appreciate that, you know, integrated planning means giving an opportunity to everybody to say, right, let's go somewhere where you haven't been before. It's a bit of a Star Trek phenomenon, but we've got to go to places where we haven't been before in order to stop people getting burnt out. Otherwise, you just continue doing the same things and you never learn.
Well, gosh, one thing I would definitely say listening to that is leadership. You know, right? That is just a fantastic example of the kind of leadership that I think is needed. We're trying to put joy back in people's working lives. And that sounds a bit trivial, but it so isn't. It so isn't. Nobody wants to go to work and feel, you know, insert your favorite adjective, yucky at the end of the day. And it's really tough. And I think that kind of leadership that that Kiran is sort of exemplifying is such a big part of what we need. I also think trying to create a more flexible workforce that allows people to experience the pathway and this from a different perspective is going to be really important as well, to start putting some juice back in the tank for people. And it's going to be a really tough winter. And so, you know, we've got to have to really remember that taking care of our people is as important as caring for our patients. We need them both. And that dynamic is how change happens. So we need to look after them both.
Brilliant.
Fabulous. Thanks so much. So you've had a lot of time asking questions of Kiran and Amy, haven't we? So just before we come to a close, I just wanted to ask some questions of the audience. So we just got these three questions that hopefully will help us just take a step back from what we've heard, kind of consolidate some of the learning and thinking that we've done throughout the session. So if everyone just takes a minute or two just to reflect on these questions, what stood out for you, any kind of light bulb moments you've had, any other reflections or unasked questions that you're taking away, and any further kind of conversation you have about this, either you and your organisation or us as a kind of Q community. So just take a minute to think through that. Please do share in the chat if you want. just give another 30 seconds or so. Please do keep them coming through. Okay, great stuff. Well, that brings us to the end of the session today. So thanks so much for joining us and your participation and questions throughout. Really hope you have found it kind of useful, insightful, enjoyable, and have appreciated the kind of very honest reflections from the celebrities. One final ask is to complete our evaluation poll. It's just a couple more questions to end on. It will genuinely take 15-20 seconds, so please do provide feedback there. And then just to end by offering a huge thank you to Clifford, Amy and Kiran for joining us today and sharing their experience and perspectives with us. So we'll bring the session to a close. There is a short break now, and then everyone's going to come back together at the end of the day for the final plenary at 3:25. So I hope to see as many of you as possible there. Thanks very much.